I'm delighted to welcome you to this wellness session. This initiative was started because a group of leaders in APSA began to realize this conversation wasn't going well. I'm sure all of you have experienced the obligatory wellness sessions in your institution. As a friend of mine once told me, if I have to go to one more session that tells me to eat well, do yoga, and be more resilient, I'm going to shoot myself. Let's be honest, we aren't well. And it's not because we aren't resilient. The Wellness Task Force was developed to look at this a different way. And as we began to struggle with defining what we wanted to do and how to think about this, we realized there were 3 different areas we needed to think about. So we created 3 groups to do a deep dive into each of these subjects and come up with recommendations. The first area was self-care, but not the way you've probably heard about it. We all know we need to eat well, exercise, sleep enough. So the real issue is how to think about self-care in practices that don't give us the space and time to accomplish those goals. This subcommittee is working on some interesting things. For instance, how to do ergonomic protection with short exercise routines you can do between cases. In other words, a really different approach to self-care for the pediatric surgeon. The second big area we chose to focus on is what we're calling recovery from injury. Let me explain. We are injured every day at work. Sometimes it's a stab wound when we lose a patient, deal with a particularly bad outcome, but more often it's paper cuts. The microaggressions we receive, the clerical work on the EMR, which can feel like death by 1,000 clicks. You know what I'm talking about. We're surgeons, so we understand that injuries, no matter what they are, need time to heal. Again, time and space that aren't often present for us at work. Finally, our third area of focus was moral injury. Working in environments that push us to provide care for revenue, working with people who may not share our values, all of these can create a sense of true moral distress. This group is working on defining the problem of moral distress and looking for unique approaches to help. Today, you're going to hear about 2 major projects that came from these discussions. First, we realized that we can't go forward without knowing where we are. So the first presentation will be the results of the wellness survey that many of you completed a few months ago. The second project you'll hear about in this session is the peer counseling initiative developed by the Recovery from Injury group. You'll be hearing more about these initiatives and other projects in the near future as we launch our web and social media presence. We want to hear from you, so please email me or anybody on the group with comments and suggestions. Stay well, friends, and enjoy this session.
Hi, I'm Christy Ryland. I'm a member of the APSA Wellness Task Force and attending surgeon at Texas Children's. And Lauren Berman and I are going to be discussing the wellness survey results. So this is just a sneak peek into the results. I'm going to give you some of the respondent characteristics, and this is a little window into the lives of pediatric surgeons. We did the survey because we wanted to understand what the sources of burnout and distress were amongst our members and provide some solutions on how to mitigate those. And then Lauren is going to talk about recovery from injury. So the survey was given in fall 2019 to all 1,300 members, and we had a 31.5% response rate. There were 32% females who took the survey. They were overwhelmingly Caucasian, and the median age was 50 years. This shows how long respondents had been in practice, with most having over 20 years of experience. Most live with a partner, children, or pets. A little over 50% did not have a pediatric surgery fellowship training program. Most practiced at an academic medical center. Most people had 3 to 5 surgeons in their practice. The majority provided services at one hospital. When on service, this is how many patients most attendings were responsible for, with the most common being 15 to 30 patients. Most respondents did not take in-house call. However, most took at-home call about 7 times a month or more. So now I'm going to go over the sources of distress and some solutions to mitigate the distress. So we asked what people most felt distressed by, and the most common answers were administrative issues and work-life balance. Then we asked 3 open-ended questions at the end of the survey, and this was asking if people could list 3 issues at work they felt most contributed to physician distress. And the most common were clinical administrative demands, poor leadership and loss of autonomy, coworkers and collegiality, and people also mentioned a lack of support and mentorship, patient complications, and work-life balance. We just wanted to provide some quotes that were illustrative of these comments. So one person said, "Our system to save costs counts on physician and nurse legal responsibility. So when the end of the day comes and the medical assistants are gone, we are left to finish up charting paperwork and other tasks that are done by other people." People also mentioned some of the poor leadership in their institution, including unrealistic demands by chiefs or chairs who do not take call at multiple hospitals and have no idea the needs of the faculty. And others mentioned the loss of physician autonomy, as executives take home millions from our labor with a fraction of the responsibility and risk. It was really important to have good workers and have a collegial environment. People mentioned having unsupportive partners, people that were not aligned on the mission. Other surgeons were distressed by partners who were, quote unquote, not pulling their weight or whose confidence was in question. And others mentioned the lack of trust and respect amongst our colleagues and other staff members. We looked at the distress amongst relationship with coworkers and looked at it by gender, and female surgeons were 3.8 times more likely than males to be distressed by their colleagues. And this quote, I think, is really illustrative of that. Someone said, "As a woman, they often do not treat me with the same respect that they give to male surgeons. In stressful situations, when men take charge, it's perceived as they were authoritative. When women take charge, someone writes up an SRS. I feel that I've tried a million things to improve this situation, but it's a constant source of stress in my life." Regarding lack of support and mentorship, someone mentioned the pressure to be a triple threat without guidance or support to achieve goals, or the selfishness of senior faculty, which leads to a loss of professional satisfaction in junior colleagues. Patient complications was also another source of distress. Someone mentioned that there were single patient issues that tended to dog you, and that a lack of resilience to handle the complications of distress only amplified that distress. Younger surgeons were more likely to feel distressed by work-life balance. One person said, "One is virtually always on and always available. A lack of downtime interferes with the necessary recovery from the unavoidable stresses of work." A lot of people mention the EMR, often with lots of exclamation points, as being a source of distress, and this trended towards being more common in older surgeons, although it was not statistically significant. So one of our other open-ended questions asked participants to list the 3 best things their institution does to promote physician wellness. And the most frequent answers were wellness programs and lectures, mechanisms to provide relief from clinical burden, empowering surgeons to partner with administrators in decision-making and problem-solving, support after adverse events, proper compensation of benefits, and opportunities for faculty development, research, and teaching. So some of the wellness programs that were effective were grand rounds about wellness topics, mandatory meetings with wellness advisors for physicians, and having the hospital pay for groups to get together and socialize. There were several mechanisms that were offered to provide relief from clinical burden. One was the expectation that people would be home for dinner, also having excellent office staff to offload the clerical work, and then having days off to compensate for weekend call. It was important to empower surgeons to partner with the administrators in decision-making and problem-solving. One person mentioned having faculty in charge of coming up with solutions to solve problems and empowering them. It's also important to have supportive chairs and division chiefs that focused on transparency and support. Support after adverse events was also important, including peer review and morbidity mortality that was done with an educational intent and a desire to improve quality and patient safety and not assign blame. It was important to have peers who go through similar things, and also important for those peers to have counseling training. And others mentioned that having great partners who are supportive and willing to shoulder patient care when one of us needs time off was important. A lot of people who responded mentioned there were programs that were just merely lip service that offered no meaningful change. These included wellness councils that just didn't do anything besides send out a lot of emails or having band-aid solutions such as mandatory trainings for wellness. Now I'm going to turn it over to Lauren.
Thank you so much, Christy. I'm going to now focus on the parts of the survey question that asked about how we recover from injury, namely our experience with adverse events related to our patients. So we asked a question about when was the last time surgeons had assisted a family with decision making for a gravely ill child needing high risk surgery. And not surprisingly, most of us have done this within the last month. And I just wanted to highlight how common it was and what a significant event it really is to participate in this kind of conversation. We also asked about how surgeons ever personally experienced a medical error that resulted in patient harm or death. Over 80% of us have. Some was in the remote past, more than 5 years ago, but quite a significant proportion was within the past year or even 6 months. So this is something that happens to many of us and will probably happen to all of us at some point in our careers. We asked those who answered that they had experienced a serious adverse event who reached out to them afterwards. One of the most common responses was that no one had reached out. The most common response was that their partners reached out or other physician colleagues, and much less frequently was institution-based programs like peer support or mental health. We asked whether surgeons were satisfied with their institution's response in helping them deal with the aftermath of the error, and the majority were either in the neutral or dissatisfied categories. So we're only about 27% said they were satisfied with their institution's response. We asked about how surgeons care for themselves when they're feeling distressed by a medical error or death, and the most common answers were talking with a life partner or with friends or performing self-care such as diet, exercise, etc. And then we asked if you were to experience a medical error or a death, would you appreciate being contacted by any of the following individuals? And one of the rarest answers was no one. So it really seems like people want to be supported. The most common answer, again, was partners in the group or other physicians. We included an institution-based peer support program, which about 40% of surgeons said they would like to be contacted. And we also included an APSA-based peer support program, which about 30% said they would want to be contacted by. So when it comes to this question of who should initiate contact, some of the open-ended responses help to elucidate why some people experience trepidation around this issue. The wording being contacted by would imply initiation from outside as a result of some alerting system. That sounds intrusive. So this is a challenging problem because we know that when people are suffering, they're much less likely to ask for help. And systems that rely on non-self-initiated contact tend to work better, but there is some trepidation around this concept. So people who had actually experienced a non-self-initiated contact had good things to say about it, such as this person who said, I appreciate that they took the time to have someone reach out. It made me feel less alone. Or this other person who said, I was contacted in the afternoon and told my next day was canceled. I met with a support person who guided me through the process of recovery. I can't tell you how much I appreciate it, and it made care for the next kid that much better. We asked about experience with lawsuits, and over half of us have been involved personally in a lawsuit. Over 70% of those who had been involved in a lawsuit said that it had a strong emotional impact on them. And again, in 43% of cases, nobody reached out to support individuals as they were going through this. So why is there such a lack of support after adverse events? There were a lot of explanations proposed for this, ranging from just avoidance, such as this person who said their colleagues were well-meaning, but often don't know what to say or don't say anything at all because of the sensitive topic. And I think that's part of the mythology around the concept of peer support. We think that nobody wants to talk about it. We think it's a sensitive topic and we don't want to go there, but it's really the opposite of what we should be doing. And then a lot of surgeons talked about having a culture of blame rather than support, such as this person who said, it doesn't matter where you work. If the error is big enough, you're thrown under the bus and nobody else wants to get on that bus with you, or that people came to M&M with pitchforks. Many people described experiences of repeated trauma after an event. And this is also well described in the literature around the second victim syndrome. The error was reviewed at 3 separate M&Ms at 2 different institutions. I was asked to write a description 2 times for 2 purposes. References went on for 6 months. It felt like repeated mental trauma. Another commented on the peer review process, saying it is very sterile and doesn't feel supportive in any way. It feels accusatory and places the physician in a defensive position, exacerbating the guilt that already exists. And I think for those of us who have been through experiences like this sounds very familiar. There was also a general feeling that the hospital shouldn't be trusted, that it will always prioritize its own interests above the clinicians. One person said the approach was simply an exercise in face saving and finding a scapegoat on the part of the administration. or that they had a mistrust in institution-based programs regarding risk management because there was a conflict of interest. So I really wanted to share this one quote about the benefit of peer support, because I really agree with this person and that it really offers a unique solution. So this surgeon said, having personally experienced a patient death, I think a peer support program in which members are given training would be optimal. Colleagues are well-meaning, but often don't know what to say or don't say anything at all. The chaplain can be helpful, but can't truly understand because they don't have the same responsibility to a patient that a physician has. So I think this is a great potential solution to this problem. So just to summarize the experience with adverse events as recorded in the survey, is that this is part of our jobs. We experience adverse events every day, some more serious than others. When this happens, many surgeons don't feel supported because there's this feeling that you need to avoid the topic or that people aren't going to want to talk about it. In the even more extreme case, there's a culture of blame rather than support. And in general, there's a mistrust in the hospital system as something that would be able to provide effective support. So when we think about our next steps with the wellness survey analysis, you heard Christy present lots of demographics and descriptive characteristics about how we practice, how vigorous our call schedule is. We asked even more. That was just really the surface of the questions, and we are in the process of doing a hierarchical regression in order to identify variables that are associated with burnout and compassion fatigue, and also compassion satisfaction, which is the opposite of compassion fatigue. So by identifying associations, we hope to inform strategies for surgeons and as well as leaders and administrators to help solve this problem. And to develop an action plan for APSA as an organization, how can it help to support surgeon wellness? And I think one of the areas that we've really been focusing on is on the area of peer support, because I think this is an area where APSA can help. With that, I'm going to introduce Kurt Heist, who will be talking about peer support for a few minutes, and we'll be happy to answer any questions at the end of his talk. Thank you so much.
I wanted to thank the APSA Board of Governors and the program committee for allowing us to share some of the work that we've done over the last couple of years in creating a peer support system. This is very much in the nascent part of its growth and our journey. There's a lot to learn about this, and we've taken some baby steps, which we'll share with you today. And then again, in the workshop, I wanted to share with you some of the background about how this occurred and why we got started in it. At the Board of Governors meeting 2 years ago, after they had reviewed their pillars of purpose here, they recognized that there was an opportunity for us to both improve our quality of care, but also improve our organizational health by learning how to provide help to one another with the difficult lifestyles that we have. One of the interesting things I noticed when we talked about this was that there were several parts of the APSA mission, like creating identity and community among pediatric surgeons and promoting a healthy environment for both patients and staff to be sure that we can grow and thrive in this environment. With that background, we were invited to create a task force that would provide some skills and talents to the APSA community. For several years now, we've been working on transitioning from a cottage-based industry where we learned interesting operations from icons in pediatric surgery who developed these procedures as they cared for rare illnesses in children. And as our profession has matured, so has our ability to measure quality and safety and subsequently improve them. We've also improved the quality of education that we provide to each other using the expert program and the Not a Textbook. But with that in mind, we still work in this environment where we are struggling with an EMR that often keeps us working till late at night, doing pajama time at home when we'd rather be with our families. Many of us work for institutions which put us in a role of piecemeal workers where we are just turning things over and have less autonomy than we anticipated. And we often, because we're very committed and passionate about what we do, we often have struggles in work-life balance. Well, we are able to measure a number of things in healthcare. Some of the things that we've noticed as we've measured this is that many of us experience burnout. And in the midst of an environment that's set up to enhance that, there's this obvious ultimate burnout item, which is an adverse event. it became obvious to us that most of us were not living and working in a culture where people were happy to talk about that. As you heard from the narratives that Lauren shared with you just a minute ago, it's easy for the families to talk about the difficulties, but most of us as physicians don't feel our culture allows us to do that. And yet we present ourselves in this manner with this happy pediatric surgeon, with a happy patient who truly looks like they have nothing wrong with them. And that persona culturally is often misleading because, as you can tell, many people are struggling with the emotional burdens of some of what they do. We all know that during our professional life, we will have an experience of making a mistake. Ideally, that mistake would be caught before it reaches the patient, but that moral distress that comes with providing care that isn't what we wanted to the patients is quite devastating. Each of us has our own families and personal lives. We can lose a parent, a spouse, lose a child, have a number of other personal challenges that affect us. In addition, not all of our patients recover from the care that we provide. Some of them have diseases and that are such that Providence speaks and we're not able to save them. And when that occurs, and occasionally lawsuits occur in addition, it can be quite devastating to the provider. If all that wasn't sufficient, then let's just spread a pandemic on top of it as well. The changes in the workflow that we've had have caused us to be isolated and not be able to provide what support that we are able to provide at this time. And when colleagues among us die from the pandemic, then those are especially devastating to us. If that wasn't bad enough, we can add to it racial intolerance and lawlessness. And there are lots of things that can keep us anxious, fearful, and on edge. So we've got a lot going on as a profession. Having said that, if there was ever a great time for us to make some changes, this would be it. This is we don't want to let good crises go to waste. We all care each day for sick children. We bring our best efforts to doing that. Why, in turn, would we not do the same thing for a suffering colleague? Why aren't we helping our colleagues when they are struggling? So we've learned that there are tools available to us, and so the silent suffering is not necessary. In the last 30 years, we've changed our cell phones. We have lots of technology that's changed. Maybe we should change our culture and how we support one another when difficulties arrive. A couple of years ago, the Board of Governors planned an outstanding 50th anniversary celebration for APSA. Dr. Herschel invited Joe Shapiro, who is a luminary in the wellness community and runs the Division of Physician Wellness and Professionalism at MGH. And she came and gave us an inspirational talk about how to care for one another and how to mature our profession in that way. At Children's in Atlanta, we started on this journey about 7 years ago and have made a lot of efforts in trying to help people to be aware of this, to train peer supporters, and then to bring professional help when necessary to a person who's struggling. We've approached this using a variety of different principles and to help both develop resilience in the person before this occurs, but also to help them when an event occurs. And so Joe gave us some working tools to work with. So in January, we invited her to Atlanta, and she spent a day with us training our hospital leaders in how to work with peer support. Our goal was to help our providers who had had an event figure out that this event did not define them, that this error or death was not going to define their entire career, that we were going to help pull them away from this keyhole and help them become stronger and better because of it. In each of our institutions, as Lauren mentioned a few minutes ago, we often have this disconnect where we assume that people want to be alone during this time, when in reality they're devastated and are so grateful when a colleague reaches out to help them. And yet most of us, as their colleagues, don't feel that this would be the right thing to do. So we're trying to change that culture. In the upcoming peer support workshop that we have next month, we intend to describe the second victim experience and help understand these stages. with a focus on helping people thrive and not just survive or leave. So here's our agenda for the peer support workshop. We'll begin by sharing experience. So pediatric surgery luminary, a senior member of our community, will talk about how they addressed an adverse event in their hospital and how their partner supported them. We'll explain the problem. We'll have a demonstration. One of my partners and I are going to walk through a peer support demonstration, and then we're going to give you a chance to practice that for a few minutes. Dr. Berman is going to teach us how to implement this at our institutions, and we'll then close our workshop by talking about these three questions. What can you do as an individual to make a change? What can your institution do, and how can we help you do that? And most importantly, now that we've made this benchmark, what should APSA do next to help you in your peer support efforts? And so we've got a lot of things going on that will help us, and a lot of things that would make us optimistic. And so we wanted to invite you to join us in July to help build this sense of community in pediatric surgery so that we would be able to help one another both during the good times as we celebrate, but also during the challenging times as well.